Hello and welcome to our GE Women's Healthcare webinar on how to diagnose endometriosis on ultrasound with our guest speaker, Dr. Suzanne Johnson. Suzanne is an associate specialist in gynecology at Princess Anne Hospital in Southampton. Her specialism is gynecological ultrasound, especially in the diagnosis of endometriosis, adnexal masses and C-section scar pregnancy. She is a fellow of the Royal College of Obstetricians and Gynecologists, certified in ultrasound imaging in the management of gynecological conditions. She plays an active role in teaching and has her own educational website on gynecologyultrasound.com. There will be a Q&A pod for questions which can be submitted during the session. The moderators of the session will review these questions. Key questions we will discuss together with Suzanne following her presentation. I will now hand over to Suzanne for her presentation on how to diagnose endometriosis on ultrasound.
We will talk about what is endometriosis, do a little video example of a pelvic ultrasound, talk about the idea classification, go back to that video example at the end, and then conclude. Endometriosis is a very common gynecological condition, and it's defined by the presence of stroma and glands outside of the endometrial cavity. These are hormonally responsive, resulting in cyclical pain, bleeding, inflammation and fibrosis, and this causes adhesions. It's a very common cause of pelvic pain, painful periods, painful intercourse, painful opening bowels and subfertility, or it can be entirely asymptomatic. We're still not sure what causes endometriosis. We recognize superficial endometriosis in the pelvic peritoneum, ovarian endometriosis in the ovary, and deep endometriosis, and this is what most of the talk will be about. This can be found in the anterior compartment and the posterior compartment, and more of that later. The mean delay between symptoms and the diagnosis of endometriosis is 8 years, and many women consult their GP many times before they're referred and diagnosed. There is significant overlap with other conditions like irritable bowel syndrome, but it's been difficult to diagnose until recent advances in ultrasound. It can also be diagnosed on MRI and laparoscopy. Often when people with endometriosis have a pelvic ultrasound, it's said to be normal, and patients are told there is nothing wrong, and this leads to long delays in diagnosis. But you need to look specifically for deep endometriosis, mobility, frozen pelvis, and site-specific tenderness. And if you don't look for these, you may say the scan is normal when it really isn't. This is an example of a pelvic ultrasound that illustrates some of these points, and I'd like you just to have a look at it, and then at the end of the presentation we will go over it again. See if you can work out where we are and what this is. It's a transvaginal scan of a pelvis. So we'll come back to this at the end. This paper was published in 2016 by the International Deep Endometriosis Analysis Group. It's an opinion on how we can diagnose endometriosis on pelvic ultrasound. They've given us a system of 4 steps which you can use in any order, and I'd like to show you my way of using this idea system. I start with a systematic routine pelvic ultrasound, specifically looking for features of endometriosis such as adenomyosis, endometrioma in the ovary and ovarian adhesions. I always ask the patient to have an empty bladder, but I don't ask for a routine bowel prep. The main thing is to be super gentle. The patient's position is also incredibly important. You need to have her bottom overhanging the edge of the couch a little bit with knee supports or feet on a chair. And then I always ask the patient, please let your knees go floppy, and that is incredibly useful. Then you very slowly and gently insert the transvaginal probe with plenty of lubricant, and then perform a systematic pelvic scan, noting also mobility and tenderness. And if I see any endometriosis, I'll also do a transabdominal renal scan, as some of these women have silent hydronephrosis. Sorry about this, but just to show you my scanning orientation, because I know not all colleagues scan in the same way. If you have the marker on the upper side of the transvaginal probe, then this fan of sound that emerges from the tip of the probe, this bit will be shown on the screen at the same place as the red dot, whereas the other side of the fan will be there. And so in a longitudinal position, the patient's head end will be at this end of the screen and her foot end at this end. And so if you look at that on an ultrasound image, there is the marker on the screen corresponding to this bit of the probe. And so this is an anteverted uterus. The bladder is up here and the patient would be there. And so you would have the bladder there, the uterus, if it's anteverted, and the bowel. So starting the systematic pelvic scan, looking for features of endometriosis. In this example, you can see that this uterus is anteverted but retroflexed, and that's at the time when you need to start looking for adhesions behind the uterus. And just to say again, if you've got the bladder here, if the cervix is pointing this way, then this means it is anteverted. If the cervix is pointing backwards, it is retroverted. And in this example, if the cervix is pointing forward but the uterus then backwards, this is retroflexed. So this uterus is anteverted but retroflexed, and that means you have to look for adhesions that are pulling the back of the uterus that way. Adenomyosis is another thing that we typically look for if we're looking for endometriosis, and this is a uterus with diffuse adenomyosis. So this is a transvaginal scan of the uterus in the longitudinal plane, scanning from one adnexa to the other. And you can see that this is a bulky globular uterus with small myometrial cysts, stripy shadows, and an indistinct endomyometrial junction. And I think we're all quite familiar with this. Adenomyosis can also look like this, where you have islands of endometrium in the myometrium. It's a very typical appearance of adenomyosis. And on 3D, that would look like this. You would have an irregular endomyometrial junction, whereas it should be clear like that. You've got a sort of budding of the endometrium into the myometrium. That's what it looks like on 3D. Then, of course, we look at the ovaries, and we're specifically looking for endometriomas, and we're all familiar with this. This is where, using the IOTA terminology, you have a unilocular cyst with ground glass echogenicity cyst contents. And again, this is longitudinal view, scanning from one adnexa to the other through the uterus, and you can see an ovarian endometrioma. You can also see how low it is. It's just at the internal os, and that's suggestive of adhesions. We'll come to that in the next picture. If you spin on this point and you now look at the transverse plane, you can see that's just the top of the cervix there. And you can see this is the ovarian endometrioma, and you can see that there's no mobility there. So it's adherent to the uterine wall, and that's an important feature to look for. And if you compare that to this patient's other ovary, you can see that that cantilevers nicely with a little bit of gentle pressure on the probe in the vagina, because that's nice and free. Now, ovarian endometriomas are rarely isolated. If you see an ovarian endometrioma, look obviously for adenomyosis in the uterus, but also look for deep endometriosis. When you have an ovarian endometrioma, you also need to look for kissing ovaries. So again, go for the transverse view. This is a different patient, but this is the top of the cervix, and you can see one endometrioma here. This is another endometrioma. They can be quite hypoechoic, and you can see that they're adherent to each other, and they're also each adherent to the back of the uterus. This is an important thing to point out in your report. So if you see a low ovary, think about adhesions. And so in this view here, we've got, this is the cervix, this is the internal os, and that's the beginning of the endometrial cavity. And you can see this ovary seems to be very low and this is very bright, and we'll come to that in a moment. But this ovary is very low, so you've got to think, well, could it be adherent to the back of the cervix? So again, spin on this point, go transverse, and you can now see that the ovary is there, it's just at the top of the cervix, and this is a thickened uterosacral ligament that it is in fact adherent to. So a useful view. But not all ovaries are adherent. Not all low ovaries are adherent, and so here's an example. This is the top of the cervix, this is the torus and the uterosacral ligaments. This ovary is low, but it's freely mobile, and it's low because it's heavy, it's polycystic. Whereas this ovary, yes, it's heavy, it's an endometrioma, but it's also adherent. So low doesn't necessarily mean adherent, but you've got to go looking for adhesions. Hydrosalpinges, well, fallopian tubes can be affected by endometriosis, but it's mainly due to adhesions, particularly if you've got kissing ovaries. And so this is an example of hydrosalpinx. This is a longitudinal view, transvaginal ultrasound, and what you can see is you can see the top of the uterus and endometrial cavity, and then here you can see the ovary, and this is the hydrosalpinx. So I'll just show that again. We've got the ovary coming in here. This is the hydrosalpinx. And so the hydrosalpinx on 3D, if you're ever not sure, put 3D on and have a look. See typical retort shape of fluid in the fallopian tube. And it's a unilocular tubular mass with thick irregular walls, incomplete septa, and some either anechoic or echogenic fluid content. So that was the systematic routine pelvic ultrasound, but specifically always looking for features of endometriosis. Next, you've got to do the sliding sign in the pouch of Douglas. These papers were published in 2013 and told us about the sliding sign. This is a normal sliding sign in an anteverted uterus. So we've got the probe in the anterior fornix, so you can see the cervix, and you very gently press your probe in and out a little bit. You don't need to block with the other hand, you just very gently press the probe in and out. This should not be uncomfortable. And then you can see that the uterus is moving one way and the bowel behind it is moving in another. So there's movement, yes, but it's not moving as a block, it's moving in opposite directions. You can see freely mobile there. And just to say, explain what I said, the probe is in the anterior fornix. This is the vagina, this is the anterior fornix, this is the posterior fornix. So if you put your probe in the anterior fornix, where most of the time your probe will be, you'll be able to see the cervix and see the sliding sign of cervix against bowel. We'll talk about the posterior fornix in a moment. When you put your probe in there, you can't see the cervix, so you can't see the sliding sign here, but you'll be able to see the posterior compartment much better. But for the sliding sign, anteverted uterus, anterior fornix. But in a retroverted uterus, remember the bladder is here, this uterus is pointing toward the patient's feet, you need to have your probe in the posterior fornix because you're looking for mobility just there, and you don't want the cervix to be in the way. So this is a beautiful normal sliding sign in a retroverted uterus. So for a retroverted uterus, you need to have your probe in the posterior fornix. Now you can't see the cervix, but you'll be able to see here clearly, and you will also be able to look at the posterior compartment in more detail. Now, when you have done an ultrasound, we are looking at the patient's right on this side and her left there by the way we set up the machine. But at laparoscopy, her right is on this side because with the laparoscope, we're looking in toward the feet. So this view of a laparoscopy in a patient who had a normal sliding sign, this is the back of the uterus. So if I play this video, you'll see that's the back of the uterus, and there on either side you'll see an ovary and a fallopian tube, but this is the area that I want you to look at. This is the torus uterinus. It's where one uterosacral ligament comes in and the other, and they merge onto the back of the cervix at the level of the internal os. And this is the pouch of Douglas. And this is a really important bit of anatomy to get your head around, the torus, because a lot of endometriosis centers on that area. So it's the insertion of the uterosacral ligaments on the posterior cervix. So we've seen what a normal sliding sign looks like in the anteverted uterus, and this is an abnormal sliding sign. So what you can see here is that yes, there's movement, but everything moves as a block. And we'll come to that a bit later, but that's deep endometriosis. So everything here moves as a block. And this patient's laparoscopy looked like this. And there's the normal, you remember. This is abnormal. All the bowel is glued to the back of the cervix, as are the ovaries, and you can't really tell what's going on beneath those adhesions. So an abnormal sliding sign in a retroverted uterus, this is the normal, and this is abnormal. And you can see there's movement, but everything moves together because everything is glued together. So we've done a routine scan and we've done the sliding sign. Now we're specifically going to look for nodules of deep endometriosis. The definition of deep endometriosis is when the lesions extend for more than 5 millimeters underneath the peritoneum. When you get cyclical bleeding in those lesions, you get inflammation and fibrosis and scarring. But it results in these irregular hypoechoic solid nodules, dark nodules, surrounded by brightly echogenic white fibrosis. So they show up rather well, dark nodules in white fibrosis. Where can you find them? Well, they can be in the posterior compartment, in the vagina, the ligaments or bowel, or all of them, and in the anterior compartment, bladder and ureter. I'm going to start with the posterior compartment because I start with an empty bladder. This is the bit I look at first. So again, here you've got bladder, uterus, vagina and bowel. And this line here is the peritoneum, and this here is the pouch of Douglas. So what you need to do is look at where the bladder attaches to the anterior uterine wall. If you draw a straight line back from that, it goes through the internal os, and then in a straight line back from that is the torus. It's where the uterosacral ligaments attach. This is your first line. Your second line is drawn at the bottom of the cervix, like that. The area between vagina and bowel below this line is the rectovaginal septum. I've never seen endometriosis there. But the top third of the vagina is called the posterior vaginal fornix, and this is where you do see endometriosis. If you're looking at the bowel, the line that includes torus, any bowel below that is called lower rectum, the bowel above that is called upper rectum, and the bowel above the level of the uterine fundus is called the sigmoid. You can have deep endometriosis here in the posterior vaginal fornix. You often see it here, retrocervical area, in the torus and uterosacral ligaments, in the lower rectum and the upper rectum, but quite often it's multifocal and it can all get glued together. This is what we call a frozen pelvis or obliterated pouch of Douglas. And if you're doing a laparoscopy, you'll be looking into that area all matted together. So you won't, in fact, be able to tell very much. This is what a frozen pelvis looks like at laparoscopy. You can see the back of the uterus, you can see the ovaries, bowel, everything is glued together, but you can't really tell what's going on underneath that. But ultrasound can tell you what's underneath those adhesions once you know what it looks like. So if we take it in turn, I always like to break things up into small components. So within the posterior compartment, I look at the vagina first because that's you're putting your probe in. It's the first area you get to. So the lower 2/3 of the vagina, the rectovaginal septum, there's no deep endometriosis there. But the top third, the posterior fornix, that's where you find deep endometriosis. So what does this look like? Well, this is a normal posterior vaginal fornix. So you can see here that this is the external os, this is the internal os, this is the cervix. And here you'll see the posterior vaginal wall come in, and this is where it blends into the back of the cervix. So this is the posterior fornix, and I'll play this video to make it more clear. And this patient has a little bit of discharge in there which outlines the fornix nicely, and that's more or less the level of the internal os, and that's where the torus is. So just to orientate you. So going just in the longitudinal plane from side to side, you can see where that posterior vaginal wall attaches to the cervix, and that's the posterior vaginal fornix. We're scanning through the anterior fornix at the moment, as you can see, because we can see the cervix clearly. So what does it look like when you put your probe in and we're passing cervix there? This is deep endometriosis in the posterior vaginal fornix. So if you put your probe in slowly and gently, it's very clear this is a nodule of deep endometriosis with little areas of hemorrhage within it. So that's what that looks like. And if you put a speculum inside the vagina, this is the posterior blade, the cervix is up here somewhere. This is that nodule of deep endometriosis almost eroding through the vaginal epithelium. So they can be seen on speculum examination, and you can feel them on vaginal examination too. So that was deep endo in the vagina. So how about the ligaments, the torus and the uterosacral ligaments? So again, just that laparoscopy, posterior uterus, torus, the right uterosacral ligament. Remember, we're looking toward her feet, so this is the right side, and the left uterosacral ligament and the pouch of Douglas. So we need to look at that area on ultrasound. So a lot of deep endometriosis centers on this area. You need to get used to looking at this area. And I find the easiest way is to look at this white line where the bladder is, attaches to the uterus, if you like. There is the internal os, and here is the torus. And it's easy to find that way. Look for bladder, internal os, and then you will see the torus. So in this scan, I'm in the longitudinal view. All of this is cervix. This is endometrial cavity. This is the anterior wall, fundus, posterior wall, and then here we've got cervix again. I'm going to go side to side a little bit in the longitudinal plane and then rotate on this point 90 degrees anti-clockwise, and that will show me the torus. Bladder attachment, internal os, and torus. So I'm just getting ready, and now I'm going to rotate. I'm at the top of the cervix internal os. This is the torus, and this fine white line is one uterosacral ligament, and that fine white line is the other uterosacral ligament. Now when they're so normal, they can be quite hard to see, and it doesn't really matter if you've got normal sliding and you can't see them clearly, they must be normal. So a lovely normal torus there, free sliding sign, and lovely sliding on both sides in the uterosacral ligaments. So a normal torus. That's one way of looking at the uterosacral ligaments, but what you find is that once you put your probe in the posterior fornix, the uterosacral ligament will blend in to this area here. So the dark line is vagina, this white line is pelvic peritoneum. We've got a little bit of free fluid, let's say from ovulation or something, and then in a moment you'll see the uterosacral ligament appear as I'm in the longitudinal plane and I've gone to one side slightly, and then when I press slightly harder in the posterior fornix, that uterosacral ligament will blend in with this, and that's important because it shows that when you're scanning through the posterior fornix, if you see adhesions, you know that at least part of that is the uterosacral ligament. So let's see what that looks like. Going slightly to the side, there's the uterosacral ligament, and now it's blended in with the peritoneum, and there it's unblended again. So slightly off to one side, uterosacral ligament, and it's pressed against the pelvic peritoneum there, and of course it will become glued down once you've got adhesions, and then because it's nice and white, it will also become thicker and whiter and fibrotic. It shows up nodules of deep endometriosis rather nicely. So vagina, peritoneum, and then the uterosacral ligament. In this case, it's normal. So that's normal, as we said. We've got the torus here, and then in the transverse view here, the torus is normal, and you press slightly, you get a nice sliding sign with normal uterosacral ligaments. This is not normal. You can see how all of this area is very bright white. That's the first thing that hits you. And this is all dense fibrosis where the tissues have all become glued together. And within that, you can see this dark lump, and there's another little bit there. This is deep endometriosis within the uterosacral ligaments. And then if you rotate 90 degrees on that, this is the torus again, and you can see very clearly that these uterosacral ligaments are very thick and fibrotic, and you can see some bits of deep endometriosis within them. This is another example of, I'm in the posterior fornix, the cervix is over there somewhere, so this is the vagina, the dark, and then the white is peritoneum and uterosacral ligaments, and this is a nodule of deep endometriosis with its spiculated edge. It almost looks invasive to me. And the way that you can see this is you need to narrow your field of view so that you're sending all your ultrasound waves to this little area. Then you need to go high frequency, as high as you can, including the highest within the harmonics range. And then lastly, you need to move your focus up so that your focus is looking at this area. And that's when you will start to see nodules of deep endometriosis. So this is deep endo within very thick fibrotic uterosacral ligaments. This is another example. You can see that we're just above the internal os there, and here again is white fibrosis with a nodule of deep endo. And at laparoscopy, this is what that looks like. There is the nodule, there are all the adhesions, so it's very clear. So we've done vagina, we've done the ligaments. How about the bowel? Bowel nodules is where you have deep endometriosis in the muscularis layer of the bowel, and it shows up as a dark mass, hypoechoic mass, often in the rectum, sometimes in the sigmoid, but sometimes also elsewhere. And it's often multifocal. If you find one nodule, look somewhere else as well. And this is a nice image of a normal bowel. So I've got my probe in the posterior fornix, the cervix is over there somewhere. I've got vagina, peritoneum, then a bit of free fluid, and then I've got a bit of lower rectum here. So the first layer here, this bright white, that's serosa. Then we've got a layer of dark white dark. This is the muscularis layer. This is normal muscularis, and the outer dark is the longitudinal layer. Then the white is a little bit of fibrous tissue, and then the inner circular muscle layer is there. So together, this is the muscularis. You can always find it because of this thin white line. Then this here is the submucosa and mucosa together. And then on the other side, you've got submucosa and mucosa just there. Here you've got normal muscularis again. This is the far side. This is always normal in endometriosis. And here you've got serosa. So we've got the lumen there, and we've got one bowel wall here and the other side bowel wall there. And this is the muscularis. This is the important one. And a good way to learn how to see this is as you're putting your probe into the vagina, if you're looking at the back, you will start to pick up this line, and then you can just track it. And this is what a nodule of deep endometriosis looks like in the muscularis. So you can see normal muscularis there, then you can see it thickening like this, and normal muscularis going out again. So just in a little bit more detail, this is this nodule of deep endometriosis. So we've got some normal muscularis coming in at either end. You can't always show that in the same image, but if you move your probe up and below, you'll see it. And then thick muscularis there. And this white layer overlying it is this submucosa, and you can tell whether that's involved by, if you see these little spiky areas, it means that the deep endo is invading, if you like, the submucosa. It's involving the submucosa. And then here you can see normal muscularis and then serosa on the other side. If you see a lesion in the bowel, endometriosis is always the proximal side, but do put colour on. This might be slightly vascular, but of course you don't want to miss a rectal cancer. It's unlikely that you will, but just to be careful. The main thing to say is that to visualise bowel nodules, you need to put your probe in the posterior fornix. Most of the time, not always, but most of the time, if you have it here, you're not going to see this area very well. But if you put your probe here, you can see the bowel beautifully. And that goes for anteverted and retroverted uterus. How to do that? Well, when you start your scan, you will naturally end up in the anterior fornix. So the patient position is very important. She needs to be, her muscles need to be relaxed to let you do this. So be sure she feels comfortable, that she trusts you, that you haven't been hurting her. Say, please let your knees go floppy and let your bottom sink into the bed. And then what you can do is you withdraw the probe a little bit, and then you angle it backwards toward the sacrum, and then gently insert it into the posterior fornix. So I'm withdrawing it a little bit, angling it back toward the sacrum, and then very, very slowly and gently inserting it into the posterior fornix. And there you can see where it attaches to the cervix. So this is now a great window into the posterior compartment. So I'll let it play once more. We're in the anterior fornix, that's the cervix going up toward the internal os there, external os there, posterior vaginal wall. withdrawing it slightly, and then this is the posterior vaginal wall. I'm just inserting the probe into that posterior fornix. There we go. There's a little bit of free fluid in the pouch of Douglas. A great look now at the posterior compartment. So bowel endometriosis can be deep or superficial. It can involve the vagina. You can say how low it is, that's really valuable, and whether or not it's stenosing. If you have superficial bowel involvement, that's when you have some endometriosis on the bowel, mainly serosa, but the muscularis layer itself looks normal. Look, outer longitudinal, fibrous and inner circular. It's normal. Whereas here, you've got deep endometriosis because the entire muscularis layer is affected. Does it involve the vagina is really important. So when you find a nodule, think bowel, ligaments, vagina to see where is it and does it involve anything else. And the reason if you found a bowel nodule that you need to look for vaginal involvement is that if these women have surgery, they're at a much greater risk of a fistula afterwards if both bowel and vagina are involved with deep endometriosis. So in this still, you can see that this vagina looks normal, and of course you need to go from one side right through to the other side in the longitudinal plane to have a good look at that. So although we've got this bowel nodule here and we've got ligament involvement here, the vagina looks normal. And you can just show that by putting the probe into the posterior fornix, and you'll see there's the bowel nodule. But if you look at the vagina itself, it's normal. You need to look at all of it, of course, not just in the very center. But here's an example where the vagina is involved. So going into the posterior fornix, and there is that lump of deep endometriosis in the vagina, and there it is in the ligaments, and there it is in the bowel. So split it up, vagina, ligaments, bowel, and then you'll see what there is. So just as a still of that was involved vagina, you can see that all of this dark, that's the DE in the vagina. Then this dark is the DE in the ligaments with thick fibrotic ligaments, and then this DE is in the bowel. So all three are involved with deep endometriosis. Very important to look for that. And this is what it looks like. Thick vaginal involvement, ligaments, and then there's the bowel nodule as well. So how low is this? How best to describe the level of this nodule that you've seen? So some colleagues measure the distance from the nodule to the anal verge. I find this really difficult. The torus is around 8 centimeters from the anal verge. So what I do is I measure the distance from the torus, and it's much simpler and it relates to a fixed anatomical point. So if the nodule is above the torus, this is upper rectum from the IDEA classification, and it'll be intraperitoneal. Whereas if the nodule is below the torus, that makes it lower rectum and retroperitoneal. And this kind of information helps to advise the gynecology surgeon whether or not they also need a bowel surgeon. So this is an example of a bowel nodule in the lower rectum. So we're going in the posterior fornix, and there you go, there's the bowel nodule. Now we're nowhere near the torus. The torus is up there somewhere, the cervix is far away. So this has got to be lower rectum. In this example, the nodule extends both in lower and upper rectum. So if you look at this still here, this is an anteverted uterus, the bladder is there. I'm in the anterior fornix. This is the level of the torus, so the bladder attachment, the internal cervical os, the torus is there, where the uterosacral ligaments insert. And this nodule is below it and above it. So it's in the lower rectum and it's in the upper rectum by this new nomenclature. So here I am, I'm staying in the anterior fornix. Would have been better to go in the posterior one. And you can see this plaque of deep endometriosis in the lower and upper rectum. You can see some normal muscularis there going into the nodule. So you know that this is muscularis layer. You can also have a higher lesion. So this is a longitudinal view of the uterus. The torus is down there somewhere. And you can see that this plaque here, that it covers the uterine fundus, and you can see normal muscularis coming out of it, and you can't see it there, but you would be able to demonstrate that if you go laterally a little bit. This is a live view of that. So that's a uterine fundus with this enormous lump of deep endo and then a big ovarian endometrioma, and it's all glued together. There is some in the ligaments, there is the bowel nodule, and then a big ovarian endometrium, and of course they all go hand in hand. It can often be multifocal too. If you've got it low in the rectosigmoid, you may have higher lesions too. So this patient, this is a low rectal lesion. You can see I'm in the posterior fornix, the cervix is over there, and I've got a low lesion there. That's some ligamentous involvement too. And then when I looked higher and near the left ovary, as you can see here are the internal iliac vessels, and I've just passed the left ovary, gone laterally a little bit. And there you can see 1, 2 sigmoid nodules. Again, they've got the muscularis layer going in and out of them at either side. You can see if you look at that nodule, normal muscularis, abnormal, normal, and the same goes for the next one. And you can see that these are bowel nodules and they're in the sigmoid, useful to have spotted. And then lastly about bowel, is it a stenosing lesion or not? So first, when you're looking at a nodule, you need to, as with anything, measure it in 3 dimensions, but you need to follow the curve if the lesion's not linear, otherwise you make it seem much shorter than it actually is. You measure the percentage of the affected circumference. What I do is I compare the width of the lesion to the width of the bowel, and then measure the angle of the deviated bowel. You can comment on submucosal involvement. I'm not sure how useful that is. So this chapter is really good if you have a look at that, and I've based this on their opinion, using surrogate markers for stenosis. If the depth of the nodule is more than 10 millimeters, if the width of the nodule is more than half of the circumference, and the angle of the bowel deviation is less than 90 degrees, these are felt to be surrogate markers for stenosis. So let's look at that. In this first example, this is a retroverted uterus, and here you can see a bowel nodule. This is it a bit magnified, and you can see that this one is flat. It doesn't bend or curve. It's a flat lesion. And looking at the bottom, this is the transverse view now of bowel, and that's a transverse view of this bowel lesion. You just, when you look at that, you rotate 90 degrees anti-clockwise. You can see that the width is less than half of the diameter. So this does not look stenosing. But if you have a curved nodule, you need to suspect stenosis. So this nodule you need to measure that way, because if you look at the white submucosa, for instance, it does that. So if you measure it this way, you make it far too short. This is the length of the nodule, and this is the angle. It's 90 degrees. That's the depth of the nodule. So be careful not to measure ligamentous involvement. Just measure the actual depth of muscularis involvement. And here we've got the width of the bowel and the width of the lesion. So it's about half the circumference. So this is also sometimes referred to as a mushroom nodule, and this looks like a stenosing lesion. You can put 3D on, and sometimes it's really helpful to do that. You take a quick volume, you render it. If you now make it move on Cine, then you've got 4D, and it just helps you to appreciate, well, the submucosal involvement in this one, and it can be really useful for measuring the width of a lesion. If patients with a bowel lesion have a colonoscopy, it's usually normal. So this is all we can tell about a bowel nodule. So you can see that with a frozen pelvis, there's just a normal one to compare against, back of the uterus there. You can see this is all you can see at laparoscopy, but on ultrasound you can see a lot more. You can see this is the same patient, the sliding sign, this is all glued together. Here you can see the transverse view, and remember everything is the other way around. That is that, and that is that. You can see everything is glued together, and what you also saw on ultrasound and not on laparoscopy is that there is bowel involvement. There's deep endometriosis in the bowel. So coming to the end now, last but not least, on your way out you need to look at the anterior compartments. Very important. If you've started with an empty bladder, which I do, then by now there will be some urine in the bladder, and it's a good time to look at the bladder and the ureters. So urinary tract endometriosis isn't that common. Here's a really good chapter on that, but it is important. It's mostly bladder endometriosis. Often women will have ureteric involvement, but this is usually fibrosis, and a fibrotic ureter can then cause hydronephrosis, which is usually silent. You need to look for it. The idea group named the terminology for us again, so that's great. The urethra and bladder, cervix, and this is where the ureter will come in. This is the peritoneum. Ureter, and then the distance between where the ureter enters and the bladder neck, that's the trigone. The area of bladder that is below the peritoneum, and it is basically adjacent to vagina and cervix up to the internal os, that's called the base, and this is where you see most deep endometriosis. And then the intra-abdominal portion is called the dome. So most deep endometriosis will be here. Again, cystoscopy is often normal. So as I say, I do it at the end. I do a sliding sign, looking gently whether the bladder moves nicely on the uterus. I look for uterine adenomyosis and then measure the nodule in 3 dimensions as ever with colour, and measure the distance between the nodule and the ureter. That's important. And then say, where is it? Trigone, base or dome? To show you what's normal, that's a urethra and a bladder. This is going to be where the left lower ureter comes in, and this is the uterus. So we're going to go in the longitudinal plane from one side to the other, always staying in the longitudinal plane, and we're going to see one ureter come in, then we're going to pass over the urethra and we'll see the other one come in on the other side. So this is the ureter, that's where we're watching. You can see it coming into the bladder, there's the bladder neck, and we're now going out the other side, and there is the other ureter, there it goes. So you can see there's the ureter, comes into the bladder, there's the trigone, and we're passing the bladder neck and going out toward the other side, and there is the other ureter coming into the bladder. So you can see they're relatively easy to find. I'm not sure how useful it is apart from when you've got a bladder nodule. So deep endometriosis in the bladder wall, we've seen normal, this is abnormal. This is a huge nodule of deep endometriosis in the bladder wall. It's pretty much covering the base and going up into the dome as well. So here it's really important to say what's the relationship between that and the ureter. So ureter, where are we going to look? Well, you can see where the ureter enters the bladder, as I just showed you, and the ureter there is often normal. The other place you can find the ureter relatively easy is here at the torus, and this is usually the area of abnormality because this is where most endometriosis centers. So we need to look at the level of the torus laterally and just posteriorly. And the other place you can often find the ureter is just by the ilex and by the ovary, a really good place. So 3 places where you can find the ureter fairly reliably. If it's dilated, what do we mean by that? More than 3 millimeters. If you put colour on, if there's no flow, it's a ureter. If there's flow, it's a vessel. And you can look for vermiculation. A ureter vermiculates, and this is what that looks like. So we're here at where the ureter enters the bladder, and you can see it contracting and discharging the urine into the bladder. This is completely normal. It's like peristalsis. It's called vermiculation in the ureter. And if you go transverse on that view and you put some colour on, you can get a pretty picture. This is a well-hydrated patient. This is the right ureter and this is the left ureter. So now you know what normal looks like. This is the ureter. I'm following it up. Quite tricky. You keep losing it, following it. Looks normal, 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 until we get to the ovary. And now you need to, I'm going back now, following that ureter back up there. But that lower ureter is normal between the bladder and the ovary. When you've then got to the ovary, you need to increase your field of view so you can look above the ovary. And what you then notice is that that ureter is very, very tight there, and then it's dilated above that area, but it's patent, you can see, but it's all glued together. The ureter is glued to the ovary. And if you look here, this is that thin ureter, and this is it thicker here, and you can see here a nodule of deep endometriosis in these fibrotic ligaments with these little spicules, like it looks a bit almost invasive. And this is the process of deep endometriosis in the ligaments that is gluing this ureter to the ovary. And you can tell that it's a ureter and not a vessel because I've put colour on. There's a vessel and there is the ureter. So when you find that, you then need to also look at the kidneys. So here's an example, longitudinal and transverse. This is a nodule of deep endometriosis. It's more easy to see in the transverse. It's adherent to this ovarian endometrioma. But look here, this is a thin ureter going toward the bladder that way. And at this point is a pinch point, and look how thick it is here, dilated ureter, and you can appreciate it better in 3D. It just gives you some slightly better resolution. So when you see that, even if you can't see it, look at the kidney. Look at this kidney. It's grossly hydronephrotic, and she never noticed a thing. So always check the kidneys. So we've done the routine scan, we've done the sliding sign, we've looked for nodules of deep endometriosis in the anterior and the posterior compartment, and last thing is soft markers, site-specific tenderness and pelvic mobility. What I do mainly is I'm very gentle. I do this right at the end of the scan, and I will go through systematically saying, right, I'm now going to see if you're sore anywhere, then very gently press on the uterus and the adnexa, etc., like you would do doing a normal systematic scan, and judge the mobility at every point and judge tenderness. And if you have got a tender area that you hadn't appreciated, look very carefully, did you miss some deep endometriosis there? For the ovaries, sometimes you need to ballot the ovary. You need to put a hand on the abdomen very gently, just to press the bowel out of the way a little bit, and the right hand's holding the probe. And you can see how this ovary was very mobile. They're not usually that mobile, but it just looks pretty. So this is the image that we had at the very beginning. So if I play this video again, then you will now know exactly what we are doing. I'll just be quiet a minute whilst you're having a look at that. And what we can see is a normal vagina. The dark area is normal. We can see very thick uterosacral ligaments. We can see a nodule of deep endometriosis in the uterosacral ligaments, and we can see a bowel nodule. There is the bowel nodule with normal muscularis going in and out of it. Normal muscularis there, thick muscularis. And we are nowhere near the cervix. The cervix is over there, so this is below the torus, so it's lower rectum, and it's close to an ovarian endometrioma. You can only see a little bit of the ovary there because I'm looking specifically just at this area. And because I break everything up during the scan, at the end I will put it all together in a little diagram, and patients find this very useful. And in this case, that was the nodule in the uterosacral ligaments. This was the nodule in the bowel, and it was very close to this ovary. And then if I look at it in a bit more detail, I could see that everything was glued together. And in the transverse plane, that ovarian endometrium and this ovary, they were not kissing. So you can tell an awful lot from a little diagram. And if you want to see this in a bit more detail, this is what I've called Live Scan 4 on the website, where I go through this particular case in great detail. So how to diagnose endometriosis on ultrasound? Start by looking for the sliding sign in all patients. Practice looking at the torus. If a pelvis looks completely normal, do learn how you would look at the torus and how you would look through the posterior fornix at the muscularis layer, learning how to find nodules of deep endometriosis. And the main thing is to be very, very gentle. Thank you.